Right, thank you. Right, well, I'm conscious of the time because we've got a very interesting session coming up after this one. Thank you very much for asking me to come along. It's an interesting session, actually. The other point I would make about the pain on the thigh is that where organs share the same innervation, you can get referred pain. So you can get testicular pain causing pain on the thigh because of this shared innervation. But anyway, that's a sort of aside that we see in the pain clinic. How did I become interested in this? Because it's an odd thing to do, really, isn't it? Well, it was that. I was stuck in a ship and was very bored. And there was an embedded reporter, this is during one of the Gulf War, and it was an embedded reporter who turned up in the sick bay and asked whether he could have a big box of antibiotics for his chronic prostatitis, which had been diagnosed by an eminent urologist in Harley Street. And it was very interesting to me, because I was sort of bored out of my mind. Because in case you don't know, wars are very boring until people start shooting at you, then they become a bit more interesting. But nothing happens most of the time. And anyway, that got me to reading. So I found at last a use for the BMA, which is a pretty amazing thing to do, really, which is that they have a very good library. And so the BMA actually flew out all these library bits and pieces for me to read. And I realised that the treatment of chronic prostatitis, certainly in 1991, was complete rubbish. But there we are, that was how bored I was. Since then we've got guidelines, which have helped a lot, except that they kind of contradict each other sometimes. But they are being refined, and at least we are getting somewhere a bit more useful. More recently, we've got this thing for UK consumption, which has been produced by the British Pain Society with urologists and all sorts of other helpful people around. If you use that URL at the top of that slide, provided you're using it from a UK address, you can get into this map of medicine section, and there is a whole section there on the management of chronic pelvic pain, which includes the stuff we're doing. Useful not for you, perhaps, but it is useful when you're talking to commissioners, when you're trying to set up an integrated service which has the necessary elements in order to be able to handle these patients properly. Because, in fact, what happens so often is that they get seen in the urology clinic where you can go through and you can see they haven't got cancer, they haven't got anything else that's worrying, and then they move on. But then they come back again. You've all seen this phenomenon of the patient on the merry-go-round, and then every so many months they return, and you need some way of putting a big boot into the mechanism of the merry-go-round to stop it. And producing a pathway which you can use from this map of medicine thing that has been produced, you can actually stop the merry-go-round, and it saves thousands of pounds. The resource implications of these people, as Professor Nichols has already said, is absolutely amazing. So do have a look at that. It won't be anything new to you because it'll be sort of sucking eggs kind of thing, but it has got lots of stuff that's helpful when you're trying to set up local services, and it's lots of stuff you can push in the direction of primary care to make stuff more suitable. Now, can't talk about pain from a pain clinic point of view without coming to the biopsychosocial model. If you look at what's happening in Canada in this unit where everybody's happy, it's difficult to work out quite what it is at the moment. I suspect that exactly what's making everybody happy apart from the outcome. What's producing the outcome? Well, I suspect what's producing the outcome is a whole gestalt thing of all of the stuff being done together, and that's what we're trying to aim for, certainly in Bristol as well. And the idea is that we have seamless pathways between the different specialists, and we then look at the whole thing there. Now, there's the biopsychosocial model. By the time the patients have got to you, and definitely by the time they've come through down to the pain side, it's looking much more like that. Where there may be a little bit of a biological trigger somewhere that we can't find, and doesn't matter too much, because what's happening now is the massive psychological distress, and also by now the social distress. And of course, because we're English, we haven't put on the other little bit, which is a bigger balloon that covers the whole thing, which would be sexual distress, because by now they're pretty hacked off in that angle as well. The question is, how do you get somebody to engage coming to talk to me who doesn't have a cystoscope or any other sort of handy, sort of high-tech stuff to hand, when they've already spoken to you? And really, this is a very difficult area, because what happens with the patients is that they can feel as though they've come to the end of the urology side, there's nothing wrong with me, but I've still got this pain. And I'm really sort of being shoved down into this second-hand car salesman trying to sort of flog me some amitriptyline or something, when I know, I've got this terrible pain. So what we have to do is we use a technique which is derived from motivational interviewing. Have you come across motivational interviewing? If you're a GP audience, all of you would have done. For hospital doctors, almost nobody does. But what motivational interviewing does is it tries to get the patient to move on so that they're actually demanding the treatment. So instead of being told, right, we've finished with you here, off you go, oh yeah, you can go to chronic pain. And they sort of think, oh, that's where the nutters with the dark glasses and the soft collars go, isn't it? Instead of that, what happens is they are gagging to get to the pain clinic. And when that happens, when we're dealing with a fertile field, as it were, psychologically, we can do a hell of a lot. So actually, you have a critical role, not just in doing the urology side of the thing, but also in handing the patient over in a way that makes them feel positive about coming down to the pain clinic. Give you a sort of typical sort of patter. Is that we would say to patients, firstly we affirm the fact, yes, you've got this very severe pain, yes, it's not imaginary, because it is pain. If you do functional MRI scans on these guys, they've got different brains from people who haven't got pain. There's something going on there that's different. If you hurt them elsewhere, they will respond differently in their functional MRI scans. And also, when you look at them, they've got these other pains often going on. There's a big link between IBS, there's a higher incidence of fibromyalgia. All of these other things tend to occur. So there is something going on. These people do have pain. So we tell them they've got pain, and it's amazing how often they sort of perk up and say, hey, someone's just taken me seriously. Okay, so you believe I've got pain. And then the next step is to try and sell them the next bit, which is to get them out of your door and into mine. And so what we do then say, we've had a lot of patients who've done very well with some of the treatments we can offer. Would you be interested in hearing about them? Now, unless the patient's completely barking and self-obsessed and not interested, they will almost inevitably drop into that trap and say, yes, I'd really like to hear about it. Now, what's happened now is you've turned it round. You're not lecturing them. You're now giving them information that they've demanded from you because they've said, yes, they want the thing. It's a bit, it's not quite as simplistic as that, but that's basically what happens. So then you tell them what can be offered. You hand them the healthy and useful leaflet that's been produced by your pain colleagues, and then they come rushing in to embrace the pain thing. That's the general idea. But life's not always like that, is it? Otherwise we wouldn't have NHS managers. Right, so what happens next? Well, just quickly acknowledging those people who've done a lot of good stuff. There's the sort of old idea. Now, when I was at medical school, which wasn't quite at the time of Descartes, pain was very simple. Now it's become much more difficult, as has been shown on the diagram on the right side, so that all sorts of things like that happen: central sensitization, peripheral sensitization, expectation, awareness, and that sort of stuff. To give you another idea, when I used to do haematology, I used to have people who used to start throwing up when they were getting ready to come to see me. This often happens. But what the reason was, they were coming to have their chemotherapy. And they were throwing up, even though they hadn't had the chemotherapy yet. They were starting to feel nauseated because they were going to come and see me. Actually, they're coming to have the drugs. And the same thing happens with pain patients. They can start to anticipate the pain. They can almost start to feel the pain before the noxious event has happened. So they're a difficult group from that point of view. So that sort of right-hand diagram is interesting and slightly annoying. There's the normal sensitization diagram. That's from Clifford Wolf's stuff, and you can see that's all very sort of nice and straightforward. And then if I move it on to the patient who's got central sensitization, you can see that changes have happened. And the changes that have happened are that the presynaptic apparatus has become more developed and is actually producing more neurotransmitter in the pain system when you get the same stimulation. Just to help matters, there are more receptors on the postsynaptic membrane, so that it gives you a much higher chance of having a lot of pain for a given stimulus. So that's the basis of your hyperalgesia. The other thing is that this descending neuron, which was very happy and blue and chunky in the previous slide, has lost his chutzpah, and he no longer is putting down the inhibitory chemical onto the postsynaptic membrane. So you're getting unopposed pain going through. Just an aside, noradrenaline is what is being released there, and that's why we use amitriptyline and the other tricyclic drugs to boost the noradrenaline levels to try and put that back into play. And then the other thing that helps a lot is this connection here. So that what should be a completely non-noxious stimulus, a feather being tickled onto whatever, becomes painful because the thing's now hardwired into the pain system. So this stuff's been well worked through, and it is what happens. And so you've got a patient with an altered system. Now, the stuff done by Irene Tracy is very interesting. I won't go into any more of that because that's an hour's lecture and she does it much better than anybody else in the world. She shows that if you take a patient who has got chronic pain and you give them a standardized painful stimulus, bits of their brain light up that shouldn't really light up. There's the emotional centers and other areas. Whereas if you do the same thing to a medical student, very much lights up apart from the bits that should light up. Although in Bristol medical students, I don't know if anything would light up. So, pain that doesn't settle, that's what we're dealing with. So the question is, have we missed anything? You know that more than I do. You know how to investigate. The U-point thing works very well. So you question the diagnosis, review, re-examine, rescan. But then once you've done it, the important thing is to make sure that any treatment that you want to offer has been done, and you're sure it's been done, the patient's sure it's been done, and even the sort of cleaner in the clinic is aware that it's been done. And then you fix the thinking. That big psychological bubble has to be brought down. And a lot of them have got straightforward psychology troubles. A few of them, actually, a larger chunk than you'd imagine, have got the sex abuse thing. I suppose that's more of a problem at Stoke Mandeville than anywhere else. And of course, that leads to a sort of PTSD type of picture. And there's this guy, Nickel, somebody on. Anyway, as you can see there, they've got numbers. These numbers are good. You see, that's bad, that's good. And that was even before they were doing the U-point thing in its full wonderfulness. So that's a sort of the way the thing goes, catastrophizing all those things that make people unhappy. In other words, you've got somebody who may still have as much pain as they walked in with, but it's no longer screwing their life up. And that's what you're after, isn't it? You may well still have some pain, but it's no longer the centre of your life. Your family become more important again. Your life becomes more important. The pain's still there, but it's now in a B-part player rather than being the starring role in your life. Drugs, we do drugs, yes, especially if we've seen the patients. Some help with the things, some don't. Many are harmful. A lot of them are terrible to take. And the other thing is that patients accumulate drugs. Have you noticed they get the pain, they go to A&E, the 4-hour wait time makes the A&E people very keen to get rid of them as quickly as possible. So what happens is they get shot with some morphine or something like this, especially IM morphine. They feel a bit better, they turn around and out the door. Very unhelpful because it rewards the behaviour. It's like Pavlovian type of thing, isn't it? That you go to A&E with pelvic pain, you get given a nice shot of something pleasant, and then you go home again. Hey, do that again. So you end up with this sort of unhelpful thing, and it costs money, and it clutters the system up. So we try and get them off those drugs. We try and get them away from the opioids, and the amitriptyline, gabapentin, pregabalin type medicines can be tried. People say don't use pregabalin for this pain. Some of the guidelines do. It's worth a try. 6 weeks of pregabalin, and away you go. But strong opioids really are a dangerous thing, because what can happen for some patients is that they treat their lives with the opioids instead of treating the pain with the opioids. And also, if they've got all of those central sensitization changes, you can probably give them a lethal dose of morphine, and the last thing they'll say is, do you know, Dr. Shipman, it still hurts. So you have to be very, very careful with these opioids, because the pains are very often completely resistant to them. So give it to us to handle the opioids. So a pathway approach to pain is what you need. Exclude the treatable. refer to us early, in a positive way, rather than well, there's nothing else I can do for you. Well, I suppose we could send you down to pain management. Let's have a positive approach. And then we need to stop the urology input. We need to stop the patient from keep coming back and cluttering your clinic up. And we need them to start to self-manage. In other words, we say to them, look, you're 5'9" tall, you're a bit podgy, you've got blue eyes, slightly receding hair, and you've got this pain, all right? It's you. It is you. Now, look, just we're going to give you the tools to move forwards with you, yourself, having a life, despite the fact that you don't look like Clint Eastwood or whoever it was he wanted to look like. He didn't have the pain either. Perhaps he did. So let's move them on. And if you're going to do anything at all, we do try and do evidence-based stuff, possibly microdenervation of the testis if necessary. But do recall the fact that you can get lovely phantom bollock pain when you've taken out a testicle, and so often I see them coming in who've developed phantom testicle pain, and the ones who don't do that, a chunk of those will develop pain on the other side. So it's a dangerous thing when you start cutting things out, and it's best done as a multidisciplinary team, really, to decide what's going on. And the other thing is that we need to be looking at RCTs. A conference on pelvic pain that I was at recently was embarrassing because people were going through 3,000 or 4,000 trials or papers and coming out with 10 that actually were able to be put into a proper meta-analysis. So we need to be doing proper studies and getting the academic stuff done rigorously. I have the same view on robotic prostatectomy. It's a very big machine, so you get a good placebo effect, provided you don't put the patient to sleep before he's seen the robot. That's an important thing, so make sure they see the robot first. And remember that the patient's recovery actually starts once you've said, yeah, actually, we've got something for you. Would you like to hear about it? So I think that's all I've got to say. Thank you very much.